My name is Massimiliano Di Pietro, and I'm consultant gastroenterologist at the MRC Cancer Unit, Cambridge University Hospital. I want to tell you about a study which has just been accepted for publication in Endoscopy journal. The article is entitled Single Bite versus Double Bite Technique for Mapping Biopsies during Endoscopic Surveillance for Hereditary Diffuse Gastric Cancer, a single-center randomized trial. Hereditary diffuse gastric cancer, or HDGC, is an autosomal dominant cancer syndrome related to germline mutation in the CDH1 gene, with a 56 to 70% cumulative lifetime risk of diffuse type gastric cancer with signet-ring cell differentiation. Symptomatic cancer can occur as early as 20 years of age, with an average age representation of 38 years. Therefore, the mainstay of treatment for HDGC is prophylactic gastrectomy, but many young individuals with CDH1 pathogenetic variants prefer to delay gastrectomy due to psychosocial reasons. In these individuals, annual or biannual endoscopic surveillance is indicated with the aim to detect foci of early cancer and inform the best timing for an operation. Endoscopic surveillance should be carried out in centers with experience in this field, with a 30-minute dedicated slot to allow for detailed inspection in white light and MBI, targeted and random biopsies. Foci of early cancer in HDGC sometimes present as subtle pale areas, but are often completely invisible, both on white light and MBI. Therefore, multiple random biopsies are recommended according to the recent HDGC guidelines. This protocol entails 30 random biopsies in all sections of the stomach, and therefore it is tedious and time-consuming. We have conducted in Cambridge a randomized controlled trial comparing the standard single bite technique with the double bite technique, whereby 2 biopsies are taken with a single pass of the biopsy forceps. There is discrepancy in the literature about the adequacy of this technique in different fields. The primary outcome of the study was diagnostic yield for in situ or intramucosal cancer. Secondary outcomes were procedural time for random biopsies, camphor score, biopsy site, and histopathological quality of the specimens. In total, we recruited 48 patients, of which 25 were randomized to the single bite and 23 to the double bite arm. The majority of our patients carried the CDH1 pathogenetic variant, but 15 of them had no detectable mutation, and they were evenly distributed between the 2 groups. The results of the study were very interesting. Foci of early cancer were equally detected in the 2 arms, which is reassuring. The double bite technique allowed 3 minutes time saving on average to take mapping biopsies. There was no difference in the camphor score, as most patients were heavily sedated. Although the biopsies in the double bite arm were slightly smaller than in the single bite arm, there was no difference in the representation of the muscularis mucosa, in the level of crushing artifact, and in the global quality of histopathological assessment. In summary, this study demonstrates that in HDGC, differently from other fields like the diagnosis of celiac disease or surveillance of ulcerative colitis, the double bite technique is entirely adequate for random biopsies, as it allows significant time saving without jeopardizing the quality of the diagnosis. Thank you very much for your attention. I hope you will enjoy this article and it might be useful for your clinical practice.